morning, everybody, and thanks to Rajat for inviting me for this session. So I'll be speaking for surface ablation in a patient who has a -3 diopter refractive error, pachymetry of 465 microns. Everything else is normal. There's normal topo, normal tomography, and biomechanics. So the first question which all of us are worried is, in a thin cornea, can we do PRK legally? I think the slides are not moving there. The slides are not moving there. The slides are not moving on the screen, yeah. It is moving in my computer. Yes. So the first question what we are all concerned is, can we do legally a PRK in a thin cornea? So this is the US FDA guidelines which tell us about the summary of the safety and efficacy of PRK and other refractive surgeries. What it tells us is that there is no mention of minimum PACI for any PRK or LASIK. What it only states is that in any case of a refractive surgery, what you leave behind, the residual stromal bed, should be more than 250 microns. And as of now, till my knowledge, I could not find any separate set Indian guidelines. Probably it is time we put some Indian guidelines. So this question is it allowed legally? So yes, if the postoperative stromal bed is more than 250 microns, you can do a PRK in a thin cornea. Second question is, why PRK? So again, there's a paper which tells us about the PTA, although this paper is applicable to LASIK, but if somehow we apply these guidelines to PRK patients, PTA of more than 40% had a highest risk of highest odds ratio of post-LASIK ectasia. In our patient, -3 diopters, if we do direct calculations, the PTA comes out to be only about 8%. So another paper which tells us about the ectasia in refractive surgery review tells us that the PRK ectasia is only 0.02% in about 1 lakh eyes of PRK. It also tells us that PTA was significantly low in PRK patients as compared to LASIK. You obviously believe that because there is no flap in PRK. And the PTA in PRK patients was 24 microns plus or minus 6%, 24% plus or minus 6%. So in our patient, the PTA is only about 8%. So it's very safe to do a PRK in this kind of a cornea. Age. So age is not specified in the case given to us, but a young age is obviously a significant risk factor in the development of ectasia. And in this Nadelman's paper, it tells us that the scoring of risk is higher if the patient is younger and lower if the patient is older. So if age is also given in this topic which is given to us, it will make it more clear. Then we come to phakic IOLs or ICLs. So are they legally allowed? Yes. Up to from -3 diopters to 20 diopters, they are legally allowed. It is efficacious. Yes, there are more than 100 papers which have told us it's efficacious. The complications usually are surgeon related and they are mostly cataracts. But the question is, if you can safely perform an extraocular surgery, then why do you perform an intraocular surgery? You can perform both eyes together, so why do you subject the patients to two operative settings? And obviously, you're doing it at 1/4 the cost of a phakic IOL. So considering all this, I would strongly believe that PRK in thin corneas is a way forward, depending upon how much RSB you're leaving. In our case, the RSB is 381 microns, so it's very safe. So I would hence state that I approve that we can do a PRK in a thin cornea. Thank you.
Thank you, Dr. Rajat. I'd like you to just wait up here. We'll get Dr. Ikeda's viewpoint and then we'll take the question.